right, good health, and welcome to today's program, Breast Cancer Awareness, the first in the series by the African American Wellness Project. I'm Dr. Mike Lenore. I am the president of the African American Wellness Project. Today's program is going to deal with breast cancer awareness in Black American females. This is a program that is part of a series of projects that we're going to do over the next few months dealing with breast cancer. We know that breast cancer has a disproportionate impact on Black American females. There are a lot of factors involved in that. Many of them are social determinants of health, but one of the factors that we're most concerned about, or as much concerned about, may surprise you. So today our program features two very special people, experts in the area of breast cancer awareness. Our first guest is Dr. Kim Rhodes. She's an associate professor of epidemiology and biostatistics at UCSF with formal training as a general colorectal surgeon. She has additional training in basic science, healthcare disparities, and health policy research. She's also trained as a community organizer at the Center for Third World Organizing during medical school. And in her current role, she serves as the Associate Director of Community Engagement at UCSF Cancer Center and the Director of Emoja Health and community-run COVID-19 testing and vaccination initiative. Dr. Rhodes is one of the few academicians which routinely shows up in our community, and we congratulate her for that. And Dr. Rhodes earned a medical degree at UCSF, a master's in health science at UC Berkeley, and a master of public health at Harvard. Our second guest is Dr. Sharon Allison Oddie. She's an energetic, engaging speaker and author, health educator, and health strategist. She's the CEO of Carden Incorporated, the Carden Co-Share Health Communities Foundation. Dr. Allison Oddie serves as a health strategist for several national companies and organizations and oversees programmatic agendas with long and short strategies, ensuring effectiveness and achievement of goals. Dr. Allison's companies have national scope and reach millions of people. She completed her 3-year residency in internal medicine at Union Memorial Hospital. During her residency training, she developed a keen interest in elderly and ultimately received training in geriatric medicine. She received her medical degree from North Carolina School of Medicine. She's a proud alumnus of North Carolina Central, where she earned degrees in biology and chemistry. Dr. Allison Oddie is an avid medical researcher with numerous publications and presentations. So we clearly have two of the best people to discuss this issue that we could possibly get. So let's start out by first of all examining the issue of breast cancer in general. The first question is, how should we monitor the possibility of breast cancer? What should a woman do at various stages of their lives as it relates to breast health? Dr. Oddie, you want to start with that?
I will. Thank you so much for having me. And I welcome participants to put comments and questions in the chat. For my followers, holler at your girl. I told y'all to join us so we can have real talk. Number one, y'all know I'm Dr. Sharon. Let's keep it real. And one of the things that's important to me is to recognize my role with the American Cancer Society as one of the spokespersons around African Americans and cancer. And certainly I'll be doing a talk for ACS tomorrow on breast cancer. And so this is near and dear to my heart. I am a woman. I have breast. So therefore, I am at risk for breast cancer. I am a Black woman who has breast. Therefore, I am at risk of breast cancer, but also of dying actually at a higher rate than my white counterpart. So what should I be doing? Certainly, we have seen the statistics, and I know we're going to get into it. African American women have a lower rate of getting breast cancer versus our white counterparts. But, and it's a big but, it's only like a 4% difference. And I believe we haven't studied it enough. But what is clear is that we die more. And I am so tired, Dr. Lenore, of saying that everywhere I go in the country. Black women get breast cancer less, but die more. So as women just across the board, we need to take ownership of our health. Number one, mammography remains the gold standard. So you need to talk to your physician or make it your own. Most of us don't even need a prescription or a referral to get a mammogram. And even if you don't have health insurance, Every state in this country allows for free mammograms. So 45 to 54-year-olds, if you're in that group, wave your hand. Every year you should be getting a mammogram. 55 or older, according to the guidelines, you may be able to go to every 2 years. However, I can say that's the guidelines. I can say for myself, Dr. Sharon, and all of my friends and everyone in that group, I still recommend, particularly Black women, that every year we're getting them. And then 40 to 44, we say talk to your healthcare. The guidelines say talk to your healthcare providers. I like to keep it simple. After 40, you got breasts, get them squeezed in a mammogram and take ownership so that you know where you are. And then finally, Dr. Lenore, I just want to say, let's have a conversation with your family. Know that if you have a family history, you have a 1.5 to 3% increase of perhaps getting breast cancer, but most women with breast cancer have no family history. So let's throw that out. That's just my opening kind of mantra. Know your breast, know your risk, and we'll talk about prevention and early detection later on.
All right. How important, once you get an idea, or either you have it, it's discovered it yourself, or your doctor has discovered it. Dr. Rhodes, how important is that biopsy?
Thank you for having me, and what a pleasure to be here with Dr. Sharon. Really enjoy some real talk, which I think is really what we need for our communities. In terms of the biopsy and how important it is, what the biopsy tells you is takes a little piece of tissue, looks at it under the microscope to determine what the cell type is. It gives some guidance about what stage the disease might be. And it tells you whether or not it is actually an invasive cancer, because some breast cancers, and I know this complicates everything, but some breast cancers are not truly cancers. They're more like precancers. And that determines what kind of treatment you're going to need. So the biopsy is actually critically important, because without documenting that it is truly cancer, no treatment will be prescribed by any medical oncologist, quite frankly.
Mm-hmm. And one of the things that we're always concerned about is what questions should people ask once they get a biopsy report of breast cancer. Too often, we get these reports and then we are so shell shocked that we're unable to kind of structure and organize our questions for people to ask the doctor or to ask the provider. Once you get a biopsy that says you have breast cancer, what are the 4 or 5 questions you'd ask during that visit? And let's go back to Dr. Sharon for that.
Thank you. It's my 3 questions that I ask. I don't care if it's toenail fungus, breast cancer, brain cancer, whatever. The basics are ask me 3. What is my main problem? Why is it important to me? And what should I do about it? In any medical situation, I helped develop these over a decade ago and tested them. If a patient, and you are shell shocked, I can't tell you how many times, Dr. Michael Lenore, people have said, as I've been speaking about breast cancer, I just stood there. I don't even know what they said after they said this is cancer. What's my main problem? Why is it important? And what am I going to do about it? That's the basics. We can take care of everything else off of those 3 questions.
And what do you agree with that, Dr. Rhodes? Is there something else that you might add to that questioning session once someone finds out that they have breast cancer?
Yeah, I think those are the big building blocks, the foundation of what's going to come next. My questions start to veer into the nitty gritty, because my research is really focused on the quality of care that people get, because we know that the quality of care determines, to some extent, the outcome. So I would be asking questions like, who is the team, right? Do we have a surgeon, a radiation oncologist, and a medical oncologist who would be prescribing chemotherapy? Does this center have a tumor board where a lot of experts come together and try to sort through the nuances, like the details of the type of cancer, the person's age, other considerations that they might have before making a decision about care. So is there a team-based approach to the care? Because part of what happens in cancer care for Black people, and again, just really based on my own research that looks at the state of California, and I'm sure this happens everywhere, but there's fragmentation in care. So you might be getting one part of your care at one hospital, the rest of your care outside of the hospital with another health system. So you want to know if there's a team-based approach so that that communication between each step in care doesn't allow the person to fall through the cracks. And then finally, the third thing I would be asking for is a second opinion. And I say that just, off the cuff, because I want people to feel like that's a normal thing to be asking for. There's no downside to having two opinions that tell you the same thing. In fact, that could give you some reassurance. If you find that there's a conflict, then you have to back up and ask the questions that I asked before. What is the quality of care at the different institutions where care is being offered? If you don't have a team-based approach and you got one opinion, then you went to a place that has a team-based approach and you got a different opinion, I would go with the team-based approach opinion. But just get used to the idea that that it's okay to ask for more information. And in fact, that's one big way that you can advocate for yourself. And then I'm sorry, the fourth question I would add is, once you're getting into the treatment conversation, is there a clinical trial for me? And I'm not here to, suggest that Black people need to sign up and be guinea pigs, but I want to point out just a subtlety about what happens in a clinical trial. And that is, when you sign up for a clinical trial, the investigator who's in charge of that clinical trial has a vested interest in you actually getting the care that you're supposed to get. Because if you don't get that care, that can harm the quality of their data. So even though it centers that investigator, it actually ends up being beneficial to the patient. And we have seen in prostate cancer and study after study, Black men do better when they're on a clinical trial. It's not because the treatment is better or they got the magical therapy. It's actually because somebody was paying attention to make sure they got everything they needed and were supposed to get, because they wanted to preserve the quality of the data collected from the trial. Regardless of how we get there, if that gets us a better outcome, I think we need to participate.
Dr. Lenore, I do want to just piggyback with Dr. Rhodes and just also say to our viewers, I don't care if you have Medicaid, you have no insurance, you have the best insurance possible. You deserve to be treated with respect. You deserve the most cutting edge medicine. You deserve a team approach. And often we see us kind of cower back because we may not be where we want to be socioeconomic, or we feel like somebody's doing a favor. No, when you walk across that threshold, you are a patient. And whether you're the president of the United States or the CEO of your house, which many of us are, you deserve the best. And I want particularly Black people to know that you are entitled to the best possible medical care.
So you're giving, the two of you are giving permission for us as patients to challenge the system or to organize the system in our own behalf. And we shouldn't be afraid. We shouldn't be afraid to do that.
Absolutely.
I mean, I wouldn't be afraid. What's at stake is your life.
That's called a rhetorical question.
But it is important, because what's at stake is your life. So as you sit back quietly and passively absorb what is being handed to you by, what we know as the status quo healthcare delivery systems, you might not get what you need. So it is important to speak up and to ask those questions. And if you don't have those questions exactly formulated, try to connect through some of these community-based organizations that will get you to someone like a Dr. Sharon or a Dr. Kim, who will act as your cousin in that circumstance and give you the questions to ask and help you interpret and understand the answers.
Yep.
Our special program today is on breast cancer awareness. Our two guests, Dr. Sharon Allison-Otte and Dr. Kim Rhodes, both experts in their own way, not only in the issue of breast cancer, but in the issue of how to get down and get it the kind of care that you need. And we're going to continue our discussion. If you've got questions, please put them in the chat and we will take them at some point that's convenient during the discussion. We want this to be an engaging hour for you. And if you have breast cancer or if you're worried about it, this may be a good time to get some of the answers that you might need. So I think it is important that we've made some good points. Obviously, we're not here to run down all the statistics or talk about all the symptoms, but I think the most important thing we talked about is that once you get the diagnosis, you need to square it up, get organized, and ask the kind of questions you need, and demand the kind of services that you need. And as we go forward in our discussion, you'll find out why that's so critically important. So let's move to another part of our discussion to talk about why Black people Black women with breast cancer have such poor, well, not such poor outcomes than whites. Always, it used to be, well, we got there late, or we didn't exercise, there was something wrong with us, and that we weren't able to organize our lives to the point where we could get the kind of screening and intervention that we needed. But more and more, as I look at these chronic diseases and they try to palm this off on the social determinants of health, I think there's another discussion to be had. What say you, Dr. Rhodes?
Well, this is definitely my sweet spot of asking our system, why are we not being introspective and looking at how we're providing care? Because as I think about myself as a Black woman living in California, why would my outcomes look like the same as a Black woman living in somewhere in the Deep South, for example, right? The only thing that we have in common is that we are both Black. And so that would suggest that there's something that happens within our systems that drive what we talk about as disparities. I like to remind people disparities is a population level problem. It's not an individual level problem. It's a population level problem, which means there has to be system level solutions. So in my own research, as I alluded to, I'm always asking the question, is the location where you're getting care equipped with the proper modalities for treatment that you're going to need to get the best outcome after this breast cancer? And so I think that one of the things that we really need to take a hard look at and also really come up with system level solutions where, for example, insurance companies don't reimburse for inappropriate care. That's how we're actually going to fix the problem of disparities, meaning that excess death that Black women experience that really is due to something that is changeable, actionable, mutable. For example, the quality of care.
Mm-hmm. Mm-hmm.
What say you, Doctor? How would you respond to that, Dr. Hadi?
Excellent point. And I just we're talking about Black women and breast cancer. And, we say that we die more, but I want to hit us in the forehead and say 50% higher death rate. It's not a little bit more. It's 50% at age 50 higher death rate. I think something happened to my screen. But anyway, 50% higher death rate. That is important. And so it cannot be that we just don't live right. It cannot just be that old poor Black people just can't do it right. We don't get for that one oncology visit. No. And there is something important that certainly is being examined. We know that, and I love what Dr. Rhodes said, we know that if you're in the South, if you're in Alabama, Louisiana, Mississippi, even Virginia, actually you get breast cancer more than white women. So there's something about geography. But the other part is, now I'm just going to be really real. When I walk across the door, what is that provider thinking about me when I walk in? Where does racism come in? Where does bias? Does he really think, or she really think, and I'll say he really think that this Black woman is not going to do nutritionally what I need to do? Do you really think that I can't afford to get to 5 treatments versus 3? Do you lower your expectations of me as a patient? Do you think I'm not going to challenge you? Do you think I'm just going to take the status quo? There is bias in medicine. Dr. Rhodes is an expert, but we all are experts. If you have been a patient in this United States healthcare system, from an MD to a no D, doctors have disparate care, has Black people. And so we have to talk about racism. It is not your fault necessarily. Now, we're going to talk about prevention and some stuff that we have to do. But I do believe, Dr. Lenore, that there is a role of racism and bias. I want the same, actually, I want better, I want the best possible care for everyone, irrespective of race. I want the best, or and socioeconomic status, and you should demand it.
Well, I always say, and I've said this pretty much with any chronic disease, if we got as mad about healthcare that was poor in quality and disrespectful as we do when someone cuts in front of us in the
Yes.
Safeway line, we wouldn't have this problem. I think that there's a certain way in which we as a culture learn how to deal with issues that we think are unfair to us. And I think too often we are soft on the healthcare system. I mean, I saw a couple of studies today which kind of reinforce that. One study that I've been repeatedly saying is that Black women who get screened for cervical cancer, sometimes they don't call you back with the results, or they don't tell you what the results are in disproportionate numbers. The study out today was a study that showed that obviously Black infants die twice as often as white
Yes.
infants, but if you deal with medically assisted interventions like fertility studies, that is 4 times as much. Now, all this couldn't be just because we're doing something wrong.
Right.
There has to be something wrong with the system. And I think there's a term that people need to understand, and then we'll take a few questions. And that's the term implicit bias. Because
Right.
I think that even though we are moving up, moving out, getting better jobs, getting bigger appointments, it doesn't matter. It doesn't matter if you're Black. The system sees you differently, and your outcomes will tend to be different. Explain
This is
implicit.
Oh,
Go ahead.
I was just going to say, yes, there's implicit bias, but then what you get to is a one-to-one, an individual level. Did this person treat me incorrectly? And I am arguing that the whole system is set up to fail for Black people. So, as I mentioned before, and I think back to my aunt who lived in Virginia and had a very advanced tumor at the time that she revealed to the family she had it. So it goes along with the story. You could say, well, you presented too late. But the reality is, for the stage of disease that she had, what she needed was radiation. What the hospital she went to didn't have was radiation. So what she got was chemotherapy, right? And so what I'm not saying is, oh, she would have survived had it not been for this horrible hospital. But what I am saying is they didn't have what she needed. And so she didn't get what she needed. And so the way her life ended was not in her own hands and of her own choice. She could have gone home. She could have made plans, right? Instead, she got sick from chemo and ended up passing away from liver failure, even though she didn't have tumors in her liver. So again, I just want to point out that I don't think it's just about implicit bias. I think Dr. Sharon's point about racism is it's racism. Because if you walk it back and you look at where Black people are allowed to get care historically, it's where Black doctors were allowed to practice historically. They're funded through largely through federal programs that are fragmented. So Medicaid, right, compared to Medicare, which is really comes from the federal government. Medicaid comes from your state to a large extent, so may or may not pay for much. Those are the hospitals where the Black doctors historically were allowed to practice. That's where the Black patients went. And in a lot of my studies where we ask a question, why do people go where they go to get their care? We love to say, oh, the social determinants and you don't have a car, so travel distance. Well, we found out that actually travel distance is neutralized if you ask a question about the characteristics of the neighborhood. People in their neighborhood go where they have gone historically to get their care. So we saw people traveling away from and farther away from NCI centers, so the highly specialized centers. We saw them bypassing high volume centers. It's because they had a relationship. That relationship is based on racism. It's based on redlining of where you can live. It's based on where Black doctors could practice. And I can speak for California, can't speak for the rest of the country. But what I will say is that the hospitals in California are still wildly segregated. I can show you several hospitals that have not seen one Black patient for a cancer diagnosis or cancer care in the course of 10 years. So we're still segregated. And what that means is where you go for care determines what you get. If you're at a safety net hospital, it would be better if you were in a trauma situation, because that's what safety net hospitals do really well. But I'm going to go back to my aunt who was in a safety net hospital. There was no radiation machine. She was not going to get radiation. So I think those are the questions that we haven't really, dug into and explored. Last thing I'm going to say is, when we look at the trend of disparities over time, what you don't see is Black women suddenly doing really poorly. You see Black women on a steady trajectory of mortality coming down. What you see for white counterparts is mortality suddenly dropping very quickly. So if
Right.
you look at that time point, you need to ask yourself, did a new medication come on board? Did a new technology emerge? Because who's getting that new technology? It's not the Black women. They're still on their trajectory.
I do have to jump in, and I want to offer also a counterpoint, because while we can talk about the system and the racism in the system and unconscious and implicit bias, let us also remember, and we are 3 Black physicians on this webinar, implicit bias and unconscious bias exist with us as well. So just because you see a minority physician does not mean that there is not bias, and vice versa. If you are a white person that sees a Black physician, so this is not to slap anybody's hands. We have to slap the system's hand, because the system is set up not for brown and Black people. But it is, again, when we talk about bias, we have to talk about, because if we are honest, all of us have some level of bias. But I want physicians and healthcare practitioners and nurses to recognize the bias. So you say, hey, let me recalibrate this. And the other thing I do from Dr. Rhodes, just want to make sure that we say, the primary care physician that is your physician that takes care of you should also always be part of your team, because of cultural competency, your trust level, and make sure that even if they're not an oncologist, that they're part of the team. We are blowing up with questions, Dr. Lenore.
Yeah, well, I'm going to bring it back to breast cancer. And the reason this is so relevant is because I don't think many discussions that I've heard in breast cancer must deal with this particular issue.
Right.
And the changes and the improvements in the care for patients with breast cancer are going so rapidly, even with precision medicine, that people need to listen to what we're saying here. We're saying that you can't trust your system to give you the latest and greatest care. You have to investigate to make sure that they can do the things that they say they can do and what their outcomes are. And so I think this is particularly unique for breast cancer, because so many people have to deal with it at so many different levels. Well, let's stop and take a couple of questions. A couple of questions deal with what we've been talking about. What steps can people take to ensure they get the same degree of care, and what attitudes should they take? We have several questions that want a few more specifics about how they go about dealing with a system that is usually even resistant to patient involvement.
Yeah, I like to point to the National Comprehensive Cancer Network guidelines, because there is a patient compendium, and I think we do have the link that maybe can get displayed for folks who are following along with this webinar. But that means that you can actually print out, okay, for my stage of disease, what should I be getting? And as soon as you see, folks veering off the track of what you should be getting, you should be asking questions. Well, the NCCN says I should be getting X, Y, or Z. And what you're looking for is a fulsome explanation of why you might be getting something different. Not as soon as you see the defensiveness, or the just, this is what you're getting and just, move on, then you have to start to question whether or not there are some limitations for that person, whether it's their own implicit bias or their lack of access to the kind of thing that you're asking for that has been published by this panel of experts that says this is what you should get if your stage of disease is X and you have the certain characteristics of your tumor. These are the treatments that are recommended by this body of experts. You should always be asking, if you're not getting that, why am I not getting that? And if the explanation comes with attitude, I think you need to question and definitely go after that second opinion.
Dr. Sharon?
Definitely the second opinion. And the other part now the other part of this is WebMD don't equal my MD. Now, the other part of that, please don't come in to your oncologist and say, can I spread turmeric all over my breast and it's going to go away because I saw some crazy study somewhere on the internet. She said, and she put the link, Dr. Rhodes said, this is a panel that sets guidelines, etc. So have the dialogue, because some things, it is personalized medicine. Well, they may say, well, no, actually you have a history of cancer and radiation to the chest, so you actually should not be getting this, but have the dialogue. And, I keep it very real. An informed patient, an impatient that comes in with a piece of paper and some questions and taking notes, doctors are, I'm sorry, we are going to sit up a little bit taller and pay a little bit more attention and do our homework. Why? Because if you know enough to research and take control of your health, you know enough to find a good lawyer to sue me. All right. So now, let's just keep it real. An informed patient, and you want to be in partnership. And so if there's a question about, what if I'm not assertive? What if I cower back? We take women with us shopping to find the best outfit. Take somebody with you. All right. Take somebody with you, write notes, and seek out, as Dr. Rhodes was saying, seek out those centers. Maybe it is 15 minutes from your house, 30 minutes from your house. If there was a flash sale on Thanksgiving Day, Friday after Thanksgiving, we'll drive an hour to get $2 off TV. Let us now take, as Dr. Lenore said, let us take control of our health and fight just as much for the better outcome.
That's real talk.
Let's go and answer a few questions that are a little bit more technical and nurturing. What are some of the factors that predict early age of onset of breast cancer? Are there parameters that people can use to structure their own profile to see if they may be at greater risk?
Do you want me to jump in, Dr. Rhodes?
Sure. Yeah.
So number one, you have breast. Okay. So every woman out here that has breast, you are at risk for breast cancer. Number two, the age of your first period. 3, if you had menopause later, and you waited for childbirth, so you were older when you went into when you had your first child. Your body weight. Somebody say ouch. Obesity is an independent risk factor for increased risk of most cancers, but including breast cancer. I dare not talk about colon because Dr. Rhodes is on here and that's her area. Breastfeeding, your number of childbirths, and menopausal, or if you've been treated with hormones. And basically, talk about your first period, and if you had your period, had hormones around longer. Basically, those are the risk factors, as well as increased alcohol, as well as I talk about a lot, nutrition. I have a whole series with the American Cancer Society on nutrition and cancer. And then just sidebar, somebody put in the chat, sidebar, there are studies going on right now. Vitamin D and calcium are being studied, has both preventive and, if you have breast cancer, linked to better outcomes, but that is a study going on. So nutrition, all of those things are risk factors. And then finally, notice what I say last, your family history. Family history of your mother or sister, 1.5 to 3 point increase in risk of breast cancer. But notice I put that last. If you got breast, that's number one. And the most predictive factor is if you have had breast cancer before, you're at the highest risk of recurrence. Did I miss something, Dr. Rhodes?
No, you didn't. I think the thing I was gonna to just raise is separate from what your risk is, but we do know that Black women and also Latina women are diagnosed at younger ages, often before menopause, which is sort of, atypical for what we believe about breast cancer, which is of course based on the pattern of disease in white women. And so that raises a little bit of an issue that I think people need to pay attention to, which is that sometimes what Black women get are called interval cancers. So you may be doing all the right things, screening at the right time, but may develop a cancer in between your mammogram. So, if you have any symptoms or you feel like there's something wrong and your intuition is telling you something's wrong, You need to persist, because for these women who are younger than where the age that we expect women to be developing breast cancer, closer to postmenopausal ages, you're going to get told, oh, you're too young to have cancer. There's no way this could be a cancer, right? It's sometimes not taken seriously because the women are younger. And that really raises a question of whether or not our screening protocols are appropriate for everybody. It may be the case that one size does not fit all, and so once a year mammogram may not work. And the populations that it is questionable in are our Black and brown women with breast.
Mm-hmm.
Yeah, well, we have a couple of questions now about what happens. Well, one technical question. One of our participants is to get a 3D mammogram, and she wants to know, is that the right way to go?
I really don't feel like I'm qualified to comment on 3D mammo versus 2D, your routine mammogram. It depends on the quality of your breast, the characteristics like the density and the sort of how much lumpiness there is, whether or not it's mostly fatty tissue. So I don't feel qualified to say, 3D mammogram is better for everybody. I don't know. Right. There are also other alternative modalities like MRI, which is just a little more expensive. Your hospital may or may not have that option. There's also ultrasound. So there are a number of different ways to screen the breast. So I wouldn't just say off the bat without really understanding or examining the person to say, yeah, you need a 3D mammogram.
So let me jump in here with the American Cancer Society's recommendations. Number one, Black women, we have more fibrocystic breast disease than other women. So we have lumpy breasts. Shout out to Black women. You got lumpy breasts, so what? It does not mean that you have more breast cancer. It just means lay off the caffeine, lay off the chocolate, and your breast hurt more. Okay, so they're a little lumpy. But know that that doesn't mean that you're at increased risk. But it does mean that you maybe have a couple of dense areas and it's harder to see if that little white mark is really breast cancer or not. So number one, get a mammogram. A mammogram remains the gold standard. Two, be in discussion. And it is good to go. Dr. Rhodes is excellent in talking about going to centers where you are not the first breast some resident just saw at a new pop-up somewhere. No, you need experienced eyes looking at your breast. 2D or 3D, again, I don't have a dog in that fight, nor are there official recommendations, but go to a breast center that is able now. Your mammogram is abnormal, then you may have to do an ultrasound and an ultrasound guided biopsy or an ultrasound or more of a compression mammogram, but those are all stages. Mammogram, according to American Cancer and all of the modalities, is still the gold standard. Something else, Dr. Lenore, that comes up is the total body scan. There are a subset of people that are saying, hey, I'm going to do the total body scan and whatever. No, we have not read enough of those total body scans to know if that shade on that left breast is cancer or you just got some talcum powder left over there. Go mammogram. And again, for myself, I have a fibrocystic breast. I know when I go get a mammogram, I'm a doctor and I'm assertive. So I usually know the radiologist and we say, okay, well, let's do a compression mammogram right now, or let's do an ultrasound guided biopsy. MRI, do not jump to MRI. Start with mammogram. If the mammogram is abnormal, MRI, because often if the MRI is abnormal, you're going to go back to mammogram anyway. Do you agree, Dr. Rhodes? Pretty much.
Yep. That's the gold standard right now.
Right now.
So,
that's right.
And I would say digital. And the
yes.
reason I'm bringing up digital is because a lot of times what we do, and I'm always seeing the subversiveness in some of these activities, but we take a van into the community, which is great to bring the care where people are. But sometimes those vans don't have a digital mammography machine. So you're getting a lower quality mammogram. And the cynical piece of this for me is when big academic centers are like, yeah, let's get a van and go out into the community to keep the people out, who are outside, keep them out. So I would really recommend that you make sure that it's digital. And if you're inside the hospital, you're more likely to get a digital than you are if you do it on a van that comes to your neighborhood. I know that's very cynical.
Get something. Get some. Take some Tylenol. Get them squeezed.
I wonder why they had all those fans running around in our community. I mean, I always wondered about the asthma fans that cost $60,000 a year for 3 asthma patients. But in any event, there's just, you've opened up a bit of a Pandora's box here, because one of our participants wants to know, if you're stuck in a system, like, I don't mean stuck, the military may not be stuck in it, but if you're in a system where you can only do this or that, and you know this or that is not enough for your breast cancer, what options do you have?
Yeah, I think those it makes it hard, because what your next option is paying out of pocket. And I think it's worth trying to go through the negotiation, and I wouldn't suggest that you go through it alone. So the idea of getting somebody to help you, who's going to maybe go to appointments, take notes for you, I would do the same if you're about to try to fight with a big healthcare infrastructure. If you are in the VA medical system, actually, there was, I don't remember the name of the piece of legislation, but its nickname is Choice. So you actually can go outside of the VA system and are supposed to be covered. Now, you've got to find a system that's going to take you, but you do have that option for a second opinion coming out of the VA medical system. Here in California, it's a little harder if you have Kaiser, for example. They really don't like to do a second opinion if they feel like, outside the system, if they feel like they can take care of it themselves. But you do have the option to pay out of pocket. And then the last thing I would say is I would look for your local community-based organizations. Often they are partnered with your local cancer center. You may not be using the cancer center, but their partners often have programs where they will pay for or drive you to or support you with, the things that you're going through in terms of trying to get a second opinion, trying to get the most appropriate care. So you have to do a little digging, and that's why I would recommend that you get a buddy, an advocate, somebody who can do some of that work for you, because a lot of your mental energy is going to be spent on, trying to deal with this big adjustment in your life.
Let me just jump in. I'm not nice. I'm not. If you go to the grocery store and you're overcharged for a head of lettuce, right? What you gonna say? The sign said it's this much, right? I want us go back to what Dr. Lenore said, advocate just as much. So when they say, well, you can't get a second opinion, say, I need you to put that in my chart. Patient, I'm asking for, I need you to write it down. That I asked you for a second opinion. You said, no, by the way, I need a copy of my records. By the way, you own your medical records. They're not doing you a favor. Ask them for your medical records. Then go to, again, if you're with United Healthcare, any of those, write and say, as medical director, you're denying my doctor's request. So often it's the doctor has requested it, and your health insurance is practicing medicine without seeing you. Say, my doctor said I need this. Who signed off on this? What doctor? So I can go after them, because they are making medical decisions for me, devoid of me and without seeing me. And I think that may be illegal. So when you do all that, I can tell you your success rate will go off the roof of you just taking time to write an email, write a letter, and document it, and say, document in the chart, I want a second opinion. Go just as hard for your best healthcare as you do for that sale of a shoe, that sale of a piece of fruit, or whatever. Because at the end of the day, and I talk too much, and the people on here that know me, that I talk too much, but I do keep it real. At the end of the day, your doctors can love you, your team can love you, your cancer team may come to your funeral and look at how cute you look in the casket with pink on, right? But they go home to their families. This is your life, and you have to take the bull by the horn. And I love that there is a man or a few men on here. Thank you. Because men, you go in and help advocate for your wives, your mothers, your daughters, your friend, your sister, girlfriend.
Yeah, that's one of the questions I wanted to ask from both of you. How do you engage and involve the family in the whole process when breast cancer is diagnosed? So often what we see on TV is the breast cancer walk, or this one celebrity individual who's got, we had followed one very famous a celebrity here, and all the way through to the very end of the process. How do you engage the family? How do you bring them into the process?
So, in my own practice, I really always liked to have a family member there, try to designate a point person who's going to be like the one point of contact to take the information. I also, and I think it's a little bit unique. I would encourage people to record the conversation to share with the rest of the family. I think for the family members who can't be there, who get to hear that recorded conversation, and just to be clear, a lot of doctors will say, no, you can't record. And I always feel like that's a red flag, because if what you're saying is not meant to be held in perpetuity, why are you saying it? But sharing that kind of recording, those kinds of notes with the rest of the family can start to draw them in. They're going to have their own questions. Those questions should then be welcomed and incorporated in to the process of the care pathway and making those decisions. And again, I would just say, if you have a physician who's not willing to be open to those questions coming from other directions, you have to ask, are you in the right place?
Right.
And then I had one last thing, which is that even though the majority of breast cancers are not familial, they are not related to a family history or an inherited, mutation or a genetic or genomic problem, I do think it's important for people to talk to each other in their families about the fact that, okay, this is happening, because there may be indications that there are other things to think about or look for. But often, if you don't know your own family history, then you cannot be fully informed to do the kind of advocacy that we're talking about. And really, what I think moves or motivates women is to think about your daughters and your granddaughters, and they need to know about this experience that you've had.
Dr. Rhodes, you are so right. And it's important also for us to recognize in the African American community that our families, our church members, our families are so expanded. So someone you trust and it says, your sister, you may not can stand your sister and don't want her in your business. That's all right. But your sister girlfriend, and someone that you can lean on, but also, and I hope we get to talk about your partner, because there are two diagnoses that go on, particularly with persons that are married or in stable relationships. It is one, and I can't tell you how many times I've talked at public talks, and we isolate men out of it, or the same-sex partner, we isolate and just say it's you. Cancer is one of the diseases that is family, and it's not just the radiation, the chemo, the all that. It is, well, I can't eat the same way anymore. I can't eat sweets. I don't feel sexy. I don't feel sexual. All of those things. And to be able to share and not feel like you're an island. So again, expand your family. Number two, put it in writing. Put down healthcare power of attorney. We must. And I have to say, please go to cancer.org, American Cancer Society site, which they have a whole area on caregiving, to-do list, all that. But also just make sure that you have designated, all of us should have a healthcare power of attorney. I don't care if you're healthy, all that. If something happens, this is a person I trust to give information to. And your doctor cannot deny your healthcare power of attorney or your consent for someone else to be in the room. They cannot deny that. But yeah, your sister girlfriend, your sister may get on your nerves, so take your sister girlfriend or your best male friend.
Well, I think the other thing about it, this is what you call advocacy, an advocate. And I always tell people, when you pick an advocate for yourself, don't pick your best friend if she doesn't know anything about health. Try to find the closest friend that you have who understands not only health, but the healthcare system. If you've got breast cancer, I try to find someone who's already been through it, so they can help you ask the right questions and answer the right things.
And support groups, American Cancer Society, and practically every neighborhood in this country, you support groups, people that will walk you through. We've done a great job, actually, has a community, even with Sisters with Breast Cancer, Sisters of Sisters, Black organizations of women that have survived it. And they're going to talk about the nitty gritty. All your hair fall out everywhere. And how do you deal with that? Real talk. How do you?
And so, I'm sorry, I just want to highlight that for Black women, because a lot of times you're in the clinic with women whose hair grows back. And for Black women, disproportionately, the hair doesn't grow back. And so to know that early on, I think is important rather than finding that out later and then being, devastated all over again. It's like another diagnosis all over again.
Right. Excellent.
Well, yeah, we have a question here about nutritional issues related to breast cancer. I think they can find that on the American Cancer Society site. They have a lot of information with regard to that, and we appreciate that. And here's another one, maybe one final question. Many professional Black women may have children later in life or at an advanced maternal age. You talked about age of your first child as a risk factor for breast cancer. Since we're speaking practically here, how do you address that?
That's one of the things that we've said about white women. Typically, Black women are having children earlier in life. And so that's been one of and I'm not sure that the data has borne it out, but it's one of the reasons we've said, oh, white women get weight and prolonged children. So professional Black women having children later in life, yes, that does increase your risk slightly, but it's not one thing that increase your risk. It's a multitude of things. So sisters, as you get older, you want to have your first baby at 40, 45. Okay, let's make sure the weight's together. Let's make sure we don't smoke. Let's make sure we know our family history. Let's make sure we're eating 5 fresh fruits and vegetables a day and exercise. Exercise has a role in cancer prevention. All of those things, and weigh the risk versus benefits. And then certainly have a discussion. This may be a time that you want genetic testing. This may be a time that you really want to go ahead and seek out someone that is a fertility specialist and say, by the way, what about my risk for cancer? What if I'm waiting, but what about my risk for cancer? And have that discussion. But it's not just one thing. It's a multitude of things that increase your risk. That's a great question. Great question.
Dr. Rhodes, you want to respond to that?
Well, I just want to add one thing, which is, for white women, they have this thing called the polygenic risk score.
Yes.
And so that takes into account all of the different things that were just mentioned, but then also the genetic testing. And what I want to just take a moment to point out is that, and this was shared with me by a colleague of mine who does research in this area. He says, if I have these 2 neighbors, they live in the same neighborhood, which means they're the same socioeconomic status, kind of same sort of privilege. One's Black, one's white. We send both of their tumors or their own whole genome sequencing. We get back some information for the white woman about their polygenic risk score. For the Black woman, we get a blank sheet of paper. Mm-hmm. And that's because there isn't enough data on or from Black women's bodies to actually accurately make those kinds of predictions. Wow. So I just want to point that out as just another reason why it's important for these studies and how we develop these scoring systems to really actually include the experiences of diverse people and not just those of white women, because we already talked about that the distribution of cancer is different in white women by age than it is in non-white women. So I just wanted to point that piece out, but I other than that, I don't have anything to add. Back on a separate question though, there is also a website. It's called thepatientstory.com.
Yes.
And this website was developed by a young woman who was it's .com, not .org. But it was developed by a young woman who was diagnosed at the age of 30 with non-Hodgkin's lymphoma, and she couldn't find any information. And so she created this site where people can share their stories, and it's broken out by the diagnosis, the stage of disease, the breast tumor receptors that are there, the estrogen, progesterone, and HER2 receptors. So you can read the story of somebody else who has the same diagnosis and some similar features and characteristics of their tumor, see what kind of treatments they got. There's a section that talks about side effects of treatment and how people mitigated it. So it really is, in my mind, this is where the magic is the People's Campaign Against Cancer. It's people informing other people rather than doctors informing, and experts, right? It's people who are experts in living in their body and walking through a cancer journey that might look similar to yours. And you can, after you, if you're in a place to do so, you can also contribute to this repository of information. And I would encourage for, women of color and Black women to contribute in these spaces, because where is that information existing otherwise for us?
Mm-hmm. Excellent.
All right, it's from a morbid perspective. We got to give some balance to this discussion to talk about males with breast cancer.
Mm-hmm.
Mm-hmm.
Yes, men get breast cancer. Yes, it is much lower incidence, and I would recommend most men are going to be diagnosed with breast cancer because they're taking a shower and they feel something in their chest. We do not have enough data, unless I have missed it in the last 24 hours, to say that Black men are at increased risk versus white men or not, because the numbers are so low. But yes, if you feel, and that's anybody, if you feel a lump, a hard, let's get to the basics, something that's hard, that is new, that is not compressible, or you have a ulceration or a rash on your chest area, breast area, those things, those are signs that you need to get it checked out. It may be an abscess, it may be a cyst, but unfortunately it could, even in a male. I think, one of the finest men ever to walk the earth, Shaft, the original Richard Roundtree, has been very vocal about his breast cancer. And so, yes, men do. And yes, former Senator Ed Brooke, thank you for saying that, died from breast cancer. Yes.
Mm-hmm. Yeah, it's about 1% of all breast
Yeah.
cancers, and for the most part, it is associated with mutations, unlike female breast cancer. So
Right.
it can be
So,
inherited. So, and this is another place where you want to be having that dialogue with your family, because if your father or a male person in your family has had breast cancer, then you really actually probably, as a first degree or second degree relative, need some genetic testing of your own. So about 6 to 8% lifetime risk of male breast cancer with the BRCA2 mutation. We don't know what the risk is with BRCA1 because most male breast
right.
cancers, if they're associated with a mutation, it's the BRCA2 mutation.
Well, I often wonder when we start programs how we're going to fill a whole hour. Well, we probably could fill another one. So I want to thank Dr. Rhodes and I want to thank Dr. Adi for sharing this information with us. Now, we know that you can get statistics on breast cancer and some of the diagnostic things that we did not focus on today because those are out there and lots of people talking about it. But the advice that we tried to give you today was for you to understand the system that you're in when you have breast cancer. That it's a system that's geared and often not in your very best interest. And so consequently, some of the advice we gave you today is some of the advice we need. And we hope from the African American wellness perspective that you will share this with your friends and share this with your colleagues, that this is information that you need that you don't often get. And we wanted to take this perspective of breast cancer. So thanks very much to our guest. Thanks to those of you who helped us put this program together. We always try to end these programs by saying, health is your biggest asset, so protect it. And we'd like to finally thank the Merck Corporation, the Merck Pharmaceutical Company, for supporting our kind of non-biased approach to discussing breast cancer in Black women and giving awareness. We'll have a subsequent program toward the end of the month.